Can you guys hear me okay? I'm a little short, so just to make sure. Okay. All right, my name's Stephanie. I'm one of the diabetes educators at our clinic in Fort Worth. We do have satellite locations that we telemed to, and I have two of my coworkers, Kelly and Candace here as well, and our PI, Dr. Shea, is virtual as she's on call. But we have a great team that I work with. I have no disclosures to report. Our objectives to evaluate trends of device use before and after QI interventions and identify areas of success within our workflow, as well as identify areas of growth to expand device use in patients with T1D. So right now, our clinic profile, we have 13 pediatric endos. This is across two locations and our main location in Fort Worth. And then we have one location in Prosper with one pediatric endo and one APP. So we have a total of 7 APPs, outpatient and 2 inpatient. We have, this says 11 diabetes educators, but that is a lie. We actually now have 8. We had 3 leave in the past month. So it's a challenge. And then our about, I don't know, 45-ish minutes away from us, we have children's and they have a few vacancies as well. So between a less than an hour distance of each other, we have basically 7 vacancies of diabetes educator positions. So it's really sad, but still trying to work through all the things. We have 5 registered dietitians, 4 medical assistants, 1 social worker. We do have 4 clinical therapists, but 2 are part-time. And then currently we have a data coordinator, but she is also leaving. So we have approximately 1,600 patients with T1D seen in the last year. And as of 2024, we had 290 new onsets for the year, but we are expecting that to be quite higher for 2025. And we have private insurance of about 64%, public of 35% for a T1D population. So the quick define the problem, the next few slides are actually from the T1D diabetes device equity change package. For what we already know about device use is the use of devices such as insulin pumps and CGMs in the management of type 1 diabetes improves glycemic control, improves long-term outcomes, improves quality of life, reduces diabetes distress, and results in high patient satisfaction. So what is actually happening as part of the change package was that there are still inequities in diabetes technology when compared to non-Hispanic white patients. The non-Hispanic Black and Hispanic patients use diabetes technology less frequently. And then individuals from high socioeconomic status and non-Hispanic white groups were more likely to be started on insulin pumps within the first year of diagnosis when compared to those who are non-Hispanic Black, Hispanic, or lower socioeconomic status. So the attitudes and assumptions and behaviors of providers are contributing factors. Studies have demonstrated a disconnect between providers' perceived biases and barriers to diabetes technology use and those with persons with T1D. And there's perceived discrimination, cultural congruence, and limited English proficiency that likely exacerbates, this disconnect between providers and patients. So at Cook, we were seeing that there was a 34% gap in CGM use between non-Hispanic white patients and non-Hispanic Black, Hispanic, and Asian patients. So this led us to try to figure out why are these things happening, which from the ADA, we know that barriers to diabetes care, there's health literacy, access, lack of social support, cost, stigma, language, cultural barriers. So when we're looking at all of these things, we kind of already know that group of people with T1D are already at risk, and then we add all these other things that are affecting that as well. So I know Candace and I, pretty much each presentation we do, we seem to come back to this graphic from the Robert Wood Johnson Foundation, and I like to use it when I'm explaining it to even people within our clinic, our staff, because they have a hard time putting it together of equality versus equity. And I think like equality is equal no matter what. So they get the same bike, right? So if we have equity, we're taking into account the inequities that exist and we're providing them a bike that works for them, right? So we're not giving the patient a bike, but we're trying to give them a CGM. So it's like we're meeting them where they are. So if they need resources in Spanish, we're giving them resources in Spanish. If they need a little bit more education on a CGM because they have no clue what it is to begin with, we're trying to give them that. But making it equal to have the access to it and then meeting them where they need as well. So this is kind of, sorry, I didn't go forward already, but our key diagram driver and part of our aim was to increase the utilization of CGM use by 10% for people with T1D by December 31st of 2024, and then demonstrate a reduction in CGM disparities by 3%. So primary drivers were, of course, address the inequities, CGM interest and access, patient education, and provider education. So going into that, we had our interventions, which we did an anonymous staff survey that revealed internal biases related to language, race and ethnicity, and insurance status. Which, as a result of that, we created CGM education that was standardized at diagnosis for all patients. CGM samples were made easily accessible on our inpatient unit. So our same diabetes educators that are outpatient go inpatient, and we just rotate through. So we would try to look at what's our stock of what we have on the floor, and then bring over brochures as well. So it wasn't a choice anymore. It was you have to do it. And we also built into our dot phrase for inpatient, was a CGM discussed? Yes or no? If it was no, what was the reason for that? Was it something that the family said that they did not want? And that's fine. You at least mentioned it. It was the family's decision to not further use it. We are very fortunate. We have something called the Peaks Tech Zone, but they're health technology advocates. So they can also assist in creating accounts, for example, for MyChart or Clarity, LibreView, whatever it may be. They are helping create those dependent accounts to make sure the patient name is matching the MRN and Epic, as we do now integrate with Gluco into our EMR. So we did have some that they're not registering their accounts properly, and we have the patient's date of birth, but the parent's name or the parent's name and the child's date of birth, and it was kind of all over. So they're helping kind of streamline that portion. If we didn't have their help, I feel like this is something that a lot of times we were either just doing, or some of the educators were saying, call the 1-800 number, contact the rep, and then it may never get done. Or they come back to clinic and still need help with that. So very thankful for that. But all patients diagnosed with new-onset T1D from 2024 through May of 2025, we ended up evaluating for CGM initiation during hospitalization. So going back to the bias survey we did, these were just a few quotes that I took out of that, which were very shocking. And I had to take several deep breaths after I read this, because it was all of like assumptions from our educators. So family is already overwhelmed or they're uninsured, or if family patient expresses refusal to wear a continuous monitor. Okay, they express that refusal, that one's fine. But just because they're uninsured doesn't mean that they don't want a CGM and we can't provide a resource for patient assistance. Or if they're purchasing test strips, they may be equaling the cost of Libre sensors per month potentially. So looking at all of those factors was not really happening. Patients solely rely on CGM if they do not get practice using a manual glucometer. Still not a reason to be able to say that they don't deserve to have a CGM. And then initially and this is in regards to bringing up the CGM. So initially I did, and I still usually do, but if family seems overwhelmed, I don't mention it unless the patient is a small child less than 6. So I guess 6 was that magical number for this, one of my coworkers. But also if they're overwhelmed, would a CGM help them not feel as overwhelmed? For me, I have T1D, and I think if my girls were diagnosed, I would 100% want them on a CGM. That would make me feel less overwhelmed and make me feel better. But it does require a little bit more education as well, of providing, okay, if the CGM alerts that they're high, can we do anything yet? Did you just dose them and they're on a meal rise? Leave it alone. Like, if we need to set our high alerts to be off to begin with, let's do that. At least have the low alerts on. But working with them for what they need and what is beneficial for that patient. So there was a lot of educator, um, I don't want to say a lot of education for them necessarily in a way of what a CGM is. It was more about biases and equity. So we did provide education for them as well as our endocrinologists and APPs. So for data analysis, I'm going to quickly go over this part, just I know for time's sake, but I think the really cool thing here is to see that our gap is closing overall and the percentage of inequities on this. So further point that out. Oh, sorry. The CGM use for all patients did improve by 6%. So it was not by a 10% at the time of the end of December of 2024. But as of September of this year, it was we were to 90% and met that 10% increase. And then our biggest win, and I think is what honestly is the most important, is we had that reduction in CGM disparities by over 3%. For non-Hispanic white to non-Hispanic Black was a 7% reduction at the end of 2024, and September was a 15%. And then as well as for non-Hispanic white to Hispanic was a 14% reduction, 18% in September. So that was very good to see there, still work to do. But our conclusion was that CGM use for all patients with diabetes can improve quality of life and improve glycemic management. And early initiation and standardization of that CGM education, I think, was key. So having those samples, having the brochures to just grab, so we bundled them together that they didn't even have to go look for anything. And then our next step on that is most likely already putting it in our binder, our New-Onset binder. So we have some of that information already in there, but it's not the actual brochure. And then other aspects of it is advocate for pharmacy coverage of CGM. So in the state of Texas, we have to go through DME for CGM, which everyone knows that is a lot more time and work to do that, but we're willing to do it to help the patients. But I think that will help make it easier. There will be less gaps in care. And if we do provide a sample that's only 10 days, or if we have an inpatient bag that's a month's supply, then they still may have a gap dependent on the DME provider. And then we're also looking at implementing the same thing for our patients with type 2 diabetes. If they've been started on insulin and have been admitted inpatient, we'll be providing them a CGM as well. So, questions?
Thank you so much. Any questions? I have a quick, oh, did you have, no. That peak tech zone, is that something that is like hospital wide, or is it specific for diabetes? Can you tell us a little more about that?
Of course. So our PEAKS tech zone is meant to be for the whole hospital, so all outpatient clinics and hospital. But we partnered with them very early, and we pretty much, I say, gave them all their business. Like, they don't charge for seeing a patient, but we referred to them a lot. And we've also partnered with them to have them come up to our clinic on certain days if we have a lot of diabetes patients that day that are not connected, or we see that there are gaps in my chart. Even we'll see, do they have staff to send one up to our clinic? There's generally 2 or 3 in our location, and then Prosper has 1. So we'll ask the families to either go down to see them. If they can come up to our clinic, they will. Or when we have a New-Onset patient, we'll send them a message once we place the sensor to ask them to go over. So it's not just us. We do have, I think nephrology uses them a lot for remote monitoring and blood pressure. And then I know cardiology uses them a little bit. The other specialties I don't think use them as much. But they're wanting us to use them so they can advocate for more positions as well.
Well, I think that's really great that you got that.
We're very fortunate to have their help. So,
any other questions online? Okay.
Awesome.
I have one last question, which is in terms of the new onset education, which I'm sure your hospital is probably like our hospital, which is our diabetes educators basically don't do all of the education, but the bulk of the education. How was it integrating CGM and the time, the extra time that it takes to do the CGM education?
That's a good question because I took it as I was doing that already. So when I thought of all these things and Kelly and Candace and I were talking about it, it's like it shouldn't be that much more. But then when I saw the bias survey, it's like, oh, yeah, it is. So it was probably about 30 minutes more, maybe give or take a little bit. But in my mind, we're saving that on the back end. I was one on the phone with families that I'm like, oh, you don't have a CGM. Did anybody talk to you about that? Oh, I was told I had to wait until the hospital follow up, or I was told I had to wait till my 3 month visit. And in my head, I'm thinking, why? Like, why are we doing this? So I'd say, well, we can go ahead and start that and then do the education on the phone. And when they came in, I make a note for somebody to look and make sure they're doing okay. But it was probably about a 30-minute more for some of our educators. But we do pretty much all of the education anyway, and our dietitian will do the carb counting component.
Very nice presentation, Sienna Kasha from Cohen Children. Actually, I just want to make a comment because I just joined Cohen Children and the curriculum was different when I joined. And I realized that our CDCs were educating patients, but it was all done in one day. And we changed I was not used to that, and I didn't think that we were giving enough time for patients to digest even what was going on. So I changed the curriculum in 2 days, same amount of time that they were, our nurses were saying they're spending. So basically 2 hours twice in 2 days. And the second day could be, even if the patient is not in the hospital, could be a remote and a follow-up visit a week later. But during that first day, all patients are going on CGM. So the rate is almost 92% of patients. I'm not sure why the other 3% are not on it, but that's another question. So I just want to tell you this comment.
Yeah, so we do it 2 days. The first day is about 2 hours, and then the second day it ranges, based on patient need, but generally an hour and a half to 2 hours. And it's the same, I've kind of wondered, it's preference of them wanting to go on it because everybody is offered. So it is interesting though that there's still more. I think some of them are leery or they have family members that have used and had issues with the sensor. So some of it's getting through those little bits too.
And then one quick question that came online, I'll try to summarize it, but they're really asking for those who didn't get on a CGM, has there been follow-up to see why they weren't put on the CGM?
Yes. So what we'll do if they're not on a CGM at our hospital follow-up, which is 3 to 4 weeks after, or I say 3 to 4, 2 to 4 weeks after diagnosis, we're talking to them again at the hospital follow-up to see, was it an insurance issue that they were waiting and wanted to make sure, or whatever it was, we're re-looking at that. And if they're still not ready, we still mention it. And then after the 3 months, our APPs or providers are kind of reviewing that and seeing what are the barriers currently. Is there anything that has changed? Is it that they decided to try it and now they have skin irritation issues and we can now look at that and help them with that? Or did they have insurance? They lost their insurance. So all of those things we're re-looking at each visit, because I think our providers like to see the CGM data. So it's more likely to have that buy-in with them to mention, have you rethought about this? And I think most of our families are open to it, at least for a CGM that previously didn't want one. The pump is a little bit different still. If they don't want it, they don't want it.
Thank you so much.
Thank you.